Started. Okay, thank you. Good evening, everyone. So people who have joined the class, just give me a thumbs up so that I can know that everyone is around. Just waiting for messages. Yeah, hi. One thumbs up from Dr. Jayaprakash, I think. Yes. Just give me a second, guys. One more point. I got a thumbs up also from people. Good evening, everyone. Good evening. So I think because of the rains, there was issue. We started slightly a bit late. Okay. But no worries. We'll continue class. Today and tomorrow, 2 days for anesthesia. So Dr. Jay, Dr. Khan, Dr. A for Andy. Just let me keep the messages ready and then we'll start. So good evening everyone. Dr. A for Andy. Okay. Trying to see it here, but I don't know, somehow that's not getting fixed. Anyways, let's start with the session here. Correct. Right. So we will be taking this session for FMGE. We'll be discussing anesthesia. Hopefully all our revision will get done. And all this will be basically the questions which have been asked recently. Okay. So these are all recent questions that you will see. We will discuss them because most of the times what happens, these are the questions which get asked again and again. So we get, oh, Dr. Med Psycho is also here. Good evening everyone. Good evening. Great to see everyone around. I think everyone is joined in. So I would like to have answers from you people so that once you get an answer, then you can discuss the same way ahead. That's how I've taken all my classes. And that's how we'll go ahead right now. Okay, so I'm ready with the messages and let's start with the class. Right, so my name is Dr. Vinish. I'll be taking up anesthesia. Okay. So anesthesia, guys, remember FMGE, number of questions, they've been very varied. They've asked you questions right from 4 questions in 1 year to I've observed 6 to in fact about 8. Okay, not more than 8, maximum 8. So 4 to 8 questions are the ones which come from anesthesia. Initially, a lot of focus was on the pharmacology of anesthesia, which is drugs like, thiopentone, ketamine, propofol, halothane, sevoflurane, desflurane. But nowadays, I'm finding questions here are less. Hi everyone, good evening. What I'm trying to say is please focus on 2-3 things, which is oxygen delivery devices. This is where maximum questions have been asked recently, after COVID especially. They've also asked a lot of questions. So they've also asked a lot of questions based on CPR, okay, and monitors. So if anyone will ask me what are the major topics that should not be missed from anesthesia, I'll rather say pharmac, yes, you have to study, I'm not denying, but please don't neglect or ignore oxygen delivery devices, CPR and monitors. Lots of questions recently have been asked from these areas itself, okay? So without wasting any more time, let's start with the first question. All these are repeat questions. I'm going to take almost last 6 papers, 5 to 6 papers of anesthesia. Most of the questions are compiled. They are all repeated questions. And so these are the compiled questions which we have, and we'll discuss their answers. And we will see as to which topics are important. 1 second, guys. I think call from the studio. Hello. So they all wanted to confirm if the class is going on or not. Okay. So, anyways, your answers, guys. So this is the first question. Please mark your answer. Oh, no, tell me the answers and then we'll discuss it out. Dr. Med Psycho has given an answer. Okay. Remember, questions from anesthesia are easy, but they are tricky. They are easy, but tricky. This is the problem with anesthesia. Dr. Khan has given one answer. Other people? Okay. So the question was, 4-year-old child is supposed to undergo hernia surgery repair. Okay. Hernia repair surgery under general anesthesia. Which of the following inhalational agent is best suited to be used for induction in this patient, right? So I think most of you have given me the correct answer. I get answers from Dr. Med Psycho and Dr. Khan, and the correct answer, as they have pointed out, is sevoflurane. Okay, so the point is, inhalational agent is what they have asked you. I'll just discuss 2 minutes. Dr. Med Psycho says children want sweets. Correct. I also remember in one more way. S for sevoflurane and S for sweet. Correct. S for sevoflurane, S for sweet. And as Dr. Med Psycho says, let's put it this way, that yes, children looking out for sweets, hence for children you will be giving them a sweet smelling agent, right? Okay, so when you speak of inhalational induction, guys, okay, induction, so remember, induction means when you're putting someone to sleep. Okay, I'm putting someone to sleep. So what is the meaning of this induction? Induction means you're putting someone to sleep, or basically patient becoming unconscious, right? So in that case, you normally prefer our IV drugs. All of us normally prefer what is called as IV drugs. And therefore, wherever possible, we try to use propofol nowadays. Wherever possible, we try to use ketamine, where propofol can't be used, and thiopentone. These are 3-4 drugs which are used, right? But the problem is, children don't let you take an IV cannula. Correct? Children don't let you take an IV cannula. So therefore, in children, what you do is, normally what we do in the children is we keep a face mask on their face. Okay, there's a mask kept on their face, and these children are awake. Okay, so when they are awake is when we put them to sleep, right? So they are awake, then we hold a mask, and after that we give them anesthesia. So remember, many times what happens, because there is no IV cannula in the child, right? So I'm holding the mask, and from there I'll be giving anesthesia. Now imagine you keep a mask on someone's face and you give a drug which is pungent, give a drug which has a dirty smell. Which child will ever forgive you? Okay. So the point is, in that case, what we did is, as Dr. Med Psycho puts in, when it comes to children or pediatric patients, right? So when it comes to pediatric patients or children, we prefer to do inhalational induction. Inhalational means I'm trying to use the mask. And here the drug I will prefer is a sweet smelling drug. So remember, the sweet smelling drug would be 2. One is sevoflurane, absolutely correct, and the other is halothane. Remember, in the old times when sevoflurane was not there, halothane was supposed to be the drug of choice. But nowadays, when sevoflurane has come, because of faster action, faster recovery, and being a drug with less complications, now sevoflurane is considered as a drug of choice because it has got a fast action and it also has got less complications. Clear, everyone? Thumbs up. Okay. So now that we are discussing these things, I would also like to say, just remember, okay, all of you, please remind me when I'm finishing of the class, maybe after an hour and a half, let me just remind me to save what I'm writing, because then you will get a PDF. Okay, annotated PDF is what we are trying to keep for you, but you have to tell me to save it, otherwise I'll forget it. It happens most of the times. Yes, guys. Okay. So Dr. Pranav Dave had also given the answer, right? D, correct. Right. So you guys need to let me know. So I'll discuss one more point over here, since we are discussing inhalational agents. So why not discuss one more point? And I would like to discuss where are the inhalational agents a drug of choice for which conditions. Okay. so that becomes easy for us to answer in the exams. So remember, whenever it's a pediatric patient, my bottle here, I'll just take it slightly away. So when it is a pediatric patient, or you need to do a inhalational induction, in that case, you will find sevoflurane as a drug of choice, right? If there is a cardiac patient, here you will find isoflurane to be the drug of choice. When it comes to neuro, there's a big question mark. Normally, a lot of people say nowadays because CO is a newer agent, we prefer it, but it's approximately the same as isoflurane, which is supposed to be good for neuro, right? So, and then when it comes to respiratory, again, you need a drug which is bronchodilator. So, sevoflurane is considered better over halothane, just like you find in pediatric patients. Both can be used, right? When it comes to liver patients, again, in liver, we would prefer, because sevoflurane is non-hepatotoxic, people prefer sevoflurane. But yes, in the old times, one of the best drugs was isoflurane. Okay. And when it comes to renal patients, kidney, you will prefer to use desflurane. It has got the least metabolism, so least fluoride ion. Okay. And daycare surgery, again, what you get to see is desflurane. So this, in short, is the drug of choice for all inhalational agents. Thumbs up, everyone. Just before exam, go through this. Okay. I'm not saying this is perfect, but yes, a lot of people might disagree with me, especially on 2 points, and that is, I'll tell you where. Different teachers teach different manners, so different ways, and different textbooks how the things are given. A lot of people might find neuro isoflurane is still better, and liver, a lot of people might think isoflurane. But just because sevoflurane is a newer drug, it has got a faster recovery. That's why I am saying I will stick my points with sevoflurane in terms of neuro, in terms of liver. But it's not that isoflurane is a bad drug. It's one of the best drug, and that is why isoflurane is one of the most common used drugs even today. Yes, everyone. Thumbs up. So let's go to the next question. Any questions and doubts you can ask me here. So I'm waiting for answers. Right. So the question is, 44-year-olds is supposed to undergo carpal tunnel surgery, anesthesia. Okay. Sorry, wrong word. Under intravenous regional anesthesia, one extra typing error. Okay. So which one of the following is the most preferred for the same? All these are questions which have been asked before. It's a repeat, it's a revision, because we always revise the last 4 or 5 times the questions which have been asked. So all these questions you people are already aware, and they cannot be ignored. More important, you cannot ignore them. Yes, guys, answers fast. Otherwise, I'll give the answer. So the question is, Dr. Pranav Dave has given the answer. Anyone else would like to agree or disagree with Dr. Pranav? Dr. Med Psycho, yes, same answer. Let's go. Correct. So all of you are right. It is lignocaine. Without wasting any more time, let's see what it is all about. So carpal tunnel syndrome, and the question is intravenous regional anesthesia, right? So what is intravenous regional anesthesia? So intravenous regional anesthesia is nothing but something which is also called as the Byers block. Intravenous regional anesthesia. So as the name suggests, intravenous regional, you are giving regional anesthesia IV. Okay. Which drugs that can be used IV? So remember, any drug which is relatively safe, okay, safe and have not having lots of complications, okay, any drug which is safe and has comparatively less complications is what you are going to use to give it IV, right? Now, when we speak of local anesthesia drugs, if you know, there's a basic classification which classifies the drugs into 3 types: drugs which are, short acting and less potent. Okay. short drugs which are intermediate acting, intermediate potent, and drugs which are long acting and highly potent. So remember, the drugs which are less potent also have less complications. These have intermediate complications, these have more complications. So these drugs which are highly potent, you will find drugs like dibucaine, you will find drugs like tetracaine, there is etidocaine, there is bupivacaine, and the derivatives of bupivacaine, which is ropivacaine and levobupivacaine. Right? So these drugs, Dr. Anshika Panwar says, Dr. Anshika Panwar, yes, good evening and hi. Of course. But my point is your answer is not very correct. That's why I'm telling you, though, please pay attention to this point. It's not ropivacaine. I'm trying to discuss the reason why it is not that. Okay. So anyways, dibucaine, tetracaine, bupivacaine, ropivacaine, and levobupivacaine are the drugs which are highly potent. They are highly toxic. They might have more complications, so these are not used. Right. So drugs which are preferred to be used are basically intermediate acting drugs, and there are two drugs which are preferred, which is lignocaine and prilocaine or prilocaine is what people say, right? So these two drugs are preferred. This is what is called as intravenous regional anesthesia, where you are giving the regional anesthesia drugs intravenously, right? So the two drugs which are commonly used are lignocaine and prilocaine or prilocaine. So these drugs have a wide margin of safety relatively. Okay. In fact, better than, if someone will ask me, better than lignocaine is even prilocaine. Okay. This relative has a wide margin of safety. It's very safe. Right. And once this drug is given IV, it can go straight away to the heart. That's exactly why they have given you a tourniquet. This tourniquet is the same thing which is used in orthopedic procedures, right? So this compresses the vessel over here, and therefore that is how the drug oozes out and starts to work like local anesthesia. Okay, so here you are going to use prilocaine or lignocaine. These are the drugs which are used, and therefore the drugs contraindicated. If someone will ask me which are the drugs contraindicated, so these drugs that you see, these drugs actually are the ones which are absolutely contraindicated and not used for any IV. Okay, and that is why you find bupivacaine not to be given IV, levobupivacaine not given IV, ropivacaine not given IV. In fact, you will find bupivacaine to be the another question asked in the exam, most cardiotoxic local anesthesia drug. Again, important point, right? Most local anesthesia drugs in terms of toxicity, we will discuss that later. You'll find other drugs not to be so toxic. So remember, the highly potent drugs are also highly toxic drugs. Okay. So these are more complications, and these drugs are contraindicated for intravenous regional anesthesia. So all the three drugs here are not to be used. Lignocaine becomes your drug which will be safe for IVRA. Okay. Next question. This was a repeat question in the last 2 years. It has been asked 2 times. Okay. In the last 2 years, this question has been asked 2 times. So waiting for your answers, guys. Tech with Alex. I first give the answer, na? Dr. Tech with Alex. Dr. Tech with Alex. Good. Nice names. Okay, Dr. Med Psycho and Dr. Khan give the answer, and they are correct. Absolutely correct. It's the diameter over here, right? So this question has been asked 2 times. Of course, the same thing might not be asked again, but remember this endotracheal tube and airway again becomes very important where questions have been asked. So the question is, the resistance of an endotracheal tube is because of what? So the first part, Dr. Pranav says A. No, Dr. Pranav, it's not A. I'll discuss the reason also behind it. Okay, it's the law which is called Poiseuille's law. Physics. Okay, it's a Poiseuille's law. So basically it's about the radius. If the radius is half, the resistance increases 16-fold. So radius you multiply by 2 becomes the diameter. So it's almost the same thing. So whether they've given you radius or diameter, that would become the correct answer, Dr. Pranav. Okay, this question is important. Think in this manner, na? If there's a small tube, if there's a big tube, big tube. Okay, there's a big tube which is there. So if something is flowing through that, because it is flowing easily, the resistance here is going to be less. But imagine suddenly this tube becomes so small and you are supposed to give the same amount of air, right? So if I'm giving the same amount of air, imagine with how much resistance or pressure it will be flowing, right? In fact, guys, don't you think this is almost the same concept why someone's blood pressure increases? Right? Is this the reason? Dr. Tech with Alex, let me give you, this is the reason for physics in MBBS, as you can see, not just MBBS, even in anesthesia. If you have a tube which is bigger in diameter and bigger in radius, you will find when something is flowing through that, whether it is the air or whether it is the fluid, it is going to have comparatively less resistance and it will become easy to flow. But when something is become constricted, which happens when someone develops a plaque, ischemic heart disease, coronary artery disease, it does not become narrowed down, but yes, the lumen of the artery becomes narrowed. So because of that, the resistance to flow increases and that increases the blood pressure. Thumbs up, everyone. Clear? Almost the same reason. Huh? It's a layman language that I'm talking about. It's not exactly the same thing, but that's what we understand. According to me, that is how it works. So when the resistance, as soon as the tube diameter or the radius is decreased, the resistance increases. So curvature, it does not depend on that. Material, it does not depend. In fact, length, I can think, yeah, after diameter, the next important point would be the length, because even the length would be important, guys. If the length is small compared to the length which is big, but yeah, compared to the two of them, I mean, if someone gives me an option that resistance depends more on length or diameter, I'll rather put it diameter before the length. Thumbs up, everyone. Is this point clear? The reason with that, I'm not saying length is wrong. Huh? Probably length is also right. It will also depend on length, but the first option ideally would be diameter and then the length. Okay. Yes, thumbs up, everyone. Okay, so this resistance increases if the radius becomes narrow, okay, or diameter is decreased. Next question. The size of endotracheal tube is decided upon by. Simple questions have come from anesthesia, guys. Simple. Though sometimes they're difficult also. There are difficult ones also that I'll discuss, but mostly they're simple. So the answer to this, see, I always wait for answers. Huh? That's how I take my classes. I like when people are responding. It is interactive. It makes you feel more like, just like how we do offline. Yeah, it's the same thing. Okay, it's responsive then. Dr. Tech with Alex understood the point why physics is important in MBBS, right? Dr. Pranav, Dr. Med Psycho, Dr. Andy. Dr. Khan has given an answer. Other people? Yes. Yes, Dr. Khan, you've given one answer. Other people, Dr. Harsh. और लोग? Dr. Harsh का आंसर आ गया. और लोग. Okay, so the size of endotracheal tube, guys, remember, as Dr. Khan and Dr. Harsh have put, which has come to me as the options, they are the ones who given me the answer. It is internal diameter. Okay, absolutely correct. So when you look at an endotracheal tube, guys, remember its parts become very important. Okay, so endotracheal tube, one point here you will see, this is the patient end. Dr. Abdul Rahman, correct. This is the patient end. And the patient end, guys, you will always find is beveled. Can you see this thing like this? This is what is called as a bevel, right? So this is the patient end. Correct. Everyone is correct, guys. You've given me the correct answer, all of you. Okay. This is the patient end where there is a bevel. This is the machine end, right? And the machine end is what is having the connector. I'm just telling you the parts of endotracheal tube because anything can be asked from here. So then you will find something written as ID over here. This ID, guys, is what is called as the internal diameter. And the internal diameter actually is the size of the endotracheal tube. So why is it so particular about internal? Because guys, there is something else also written on the tube. If you'll find, if you can see, it's written over here, outer diameter. If internal diameter is 8, can you see there is something written as outer diameter? This is the external diameter of the tube. So if I have to show you, can you see this? This is what is called as the outer diameter. This is the internal diameter. So internal diameter is what determines the size of the endotracheal tube. Outer diameter is the outer diameter of the tube, right? So this is the outer diameter. That does not tell you the size. Okay, this does not tell you the size. Then the endotracheal tube itself has written, you know, oral or nasal, both it can be used, and it is a single use, right? Next question I want to ask you, what is this? What is that? This point is called what? This is asked in the exam. By the time you ask me this, I'll answer this point to me. Till then, I'll describe the other points of the endotracheal tube to you. So from the endotracheal tube, I told you this is the patient end where you get the bevel. Bevel is basically something like this. Okay, this is what is called a bevel, right? And most of the things in anesthesia or even a medical profession are made with bevel to minimize the tissue damage. So this is what is called as a bevel, right? So I've been asking you about this point. This one, what is this? Dr. Khan says vocal cord. Correct, it's called vocal cord marker. Vocal cord marker, vocal cord guide. So this black line that you see over here, this is called vocal cord marker or vocal cord guide, which is supposed to lie at the vocal cord. Correct, absolutely correct. Same thing you will see over here. This is how we know where to keep the endotracheal tube and how much depth you have to insert. This is what is called vocal cord marker. So what happens is when you put endotracheal tube, your vocal cord marker is supposed to be lying here close to the vocal cords, and that's exactly what is the significance of the black line. Okay, this is the cuff, this was the patient end, here is the connector. As you can see, we have to insert beyond vocal cord, not ideally, no, the black line is supposed to lie at, if this was the black line, so it is supposed to lie at the vocal cord. So if there is a vocal cord here, the black line is supposed to lie at the vocal cords. The black line is supposed to lie at the vocal cords. Okay, that's why it's called vocal cord marker. The next thing that you see here is the cuff, right? And the cuff gets inflated from here, which is called as the pilot balloon, right? And there is an inflation line. So when you put air from here, the air will travel from the tube like this. This tube from where it is traveling is called inflation line. Forget that, that's not very important, forget that, right? But still I mention it out to you, and it goes from here into the cuff to inflate the cuff, and that is how the cuff gets inflated, right? That is exactly how the cuff gets inflated, which prevents aspiration. Someone is vomiting, so the stomach contents have come here, they are getting regurgitated, and when it comes for aspiration, can you see when you inflate the cuff, it has decreased the chances of aspiration. This becomes one of the reasons to intubate someone. So the two most important points why you want to intubate someone is so that oxygen can go in, carbon dioxide can come out, which means you have to maintain a patent airway. And second, you want to protect the airway from aspiration. So patent airway and protect the airway, right? That is the indication for intubation of a patient. All right. The other markings that you see, which are over here, these are called centimeter markings from the tip. They also tell you where exactly it is supposed to be placed. Can you see this number is 18, 20, 22, 24. So here at the mouth, you normally in a male patient, you will be keeping 21 to 23. In a female patient, it has to be 19 to 21 at the lip or at the mouth. So this is again one way how you insertion depth you come to know. So these are called centimeter markings from the tip. So these are centimeter markings from the tip. And last point that I will tell you is there is a blue colored radio opaque line which can be seen on the X-ray. So this question is important not just for people preparing for FMGE, NEET PG, INICET. This endotracheal tube, guys, is also asked to people who are in the final prof when they're attending their viva, and someone gives them an endotracheal tube to identify as an instrument in the exam. This is what is there. Okay, lots of time people don't pick up an instrument. They say endotracheal tube is dangerous, but if you know the endotracheal tube, it's never dangerous. You can answer the examiners, guys. So be confident. Whether you're giving your final prof viva exam, you're appearing in INICET, FMGE, or NEET PG. Okay, so next question. So we are done with the endotracheal tube, and I discussed with you all these points here. So the correct answer was the internal diameter, not the curvature, not the external diameter, not the length. Going forward, next question. Okay. So answer fast so that I can cover up as many as we can. Questions. As I said, this is a revision. And most of you are giving me correct answers, which means you are well prepared. Dr. Pranav gives the answer. Absolutely correct, Dr. Pranav. Absolutely correct. So I'm saying you people are, if these are the ones. Dr. Harsh says A, Dr. Med Psycho says A. Correct, correct everyone. So A is the correct answer. Without wasting any more time, remember this is oxygen delivery device, nasal cannula. So this time exam itself, they had asked you 2 questions based on that. This is the nasal cannula, guys. Nasal prongs. It's also called as the nasal prongs or nasal cannula. Okay. It can be called nasal prongs or nasal cannula. Now, this works between, as I said, as you can see, okay, 0.24 to 0.44. So maximum FiO2 that you get from this 0.44. This can also be said as 44%. Okay. For example, room air that we breathe is 21%. Right? Room air is 21%. So someone is hypoxic, not able to breathe, you will want to give more oxygen than the room air. If room air is 21%, you don't want to give that, you want to give more. The nasal prongs can give maximum of 44%, and which is the same thing as 0.44. Okay, so that is the question which was asked. So it delivers more than the room air. Room air is 21%, so this delivers 24% to almost 44%. As you say, some books have mentioned 45%, same thing. So this becomes the correct answer. Okay, 0.24 to 0.45. So there are others also. Let's discuss them out. Let's take this question and then we'll discuss this whole point of oxygen delivery devices. Okay, so here the correct answer, guys, was A, which all of you have marked correctly. Everyone has marked correctly. Next question. Okay, so Dr. Med Psycho says one answer, correct. And what else? Other people? Dr. Pranav Dave has said one answer. Dr. Khan, Dr. Harsh has said one. Okay. Dr. Harsh, don't worry, I'll clear your doubt out. Don't worry, Dr. Harsh. Other people who have marked it C right now is correct. Dr. Harsh has said D, but no problems. You can do mistakes here. Mistakes are not to be done in the exam. It's good if you do a mistake here so that we can discuss. Dr. Tech, everyone has said C. Everyone. Correct. Venturi mask. Okay. Absolutely correct. Is it a nasal cannula? Okay, first read the question. Which one of the following devices can provide a fixed, controlled oxygen irrespective of patient's respiratory effort? So what they're asking you is, where do you know how much is the exact oxygen getting delivered to the patient? Okay, how much exact oxygen is being delivered? Matlab, you're not worried about the patient's respiratory effort. I'm not worried about what the patient is breathing or not breathing. How much you are giving to the patient, whether you know it's exact or not. So this is what is called as a Venturi mask. In a Venturi mask, as you can see, this is what is called as a Venturi mask. You see, this one is a green colored one. It has written that, it is going to give 60%. It's also written 15 liters. So when you start 15 liters of oxygen from the flow meter, from the one which is there in the wards, you are going to give 60% to the patient. So you are not worried about the patient's respiratory effort, but how much exactly you are going to give? I'm going to give 60% if I start 15 liters and I use the green one. If I use the red one, how much exact will go? 40%. If I use the yellow one, 35%. Orange one, 31. Okay. If I use the white, it is 28. If I use blue, it is 24. You are not supposed to remember these colors, guys. They will not be asked in the exam. They are also color coded, but will not be asked. So basically, this is a Venturi mask, guys. And out of the oxygen delivery devices, okay, so if someone will ask me oxygen delivery devices, I classify them into two types. Okay, so oxygen delivery devices, let's discuss this point. It's an important one, so pay attention, all of you. Oxygen delivery devices, we can basically classify them into two types. Okay, so we can go like this. One is going to be the low flow devices. The others would be a high flow device. There are other ways also. Huh? Some people have also included one more classification. Actually, it's like that only, which includes the reservoir systems with reservoir. I'm not including that for the sake of discussion and making things easy. That's the reason I'm not including, because you don't need to know the classification. You just need to know about the instruments. So low flow devices, the first one is the one which we saw, nasal prongs or nasal cannula. Remember, the maximum FiO2 which can go here is 44%, not more than that. Okay, it works between 1 to 6 liters. Then, but 44% is too less for someone who's hypoxic. Then we use our standard face mask. The standard face mask is also called a simple face mask. It's also called a Hudson face mask. It can be called standard, simple. The maximum FiO2 is 60%, and this works between 5 to 10 liters of oxygen. Right? 44 to 60 is still less, yeah. It's not totally, absolutely good for a patient who's hypoxic. So what they did was, in the same, so if this is the nasal cannula, right? This is the nasal prongs. This is giving 44%. So they made a simple face mask, right? A simple face mask gives 60%. So in the simple face mask, they attached a reservoir bag. Can you see this? So this attachment of the reservoir bag made it a partial rebreathing mask. And when you have a wall with it, it becomes non-rebreathing mask. So this will give anywhere between 70 to 90%. And that is why in COVID, this is what was used maximum during the COVID times. The face mask, which a reservoir, that was called a non-rebreathing mask, NRBM. Okay. So face mask is the Hudson mask or the standard mask. Then you have something called as a partial rebreathing mask. It can give 70%. It works between 10 to 12 liters. However, the best is the non-rebreathing mask. Okay. And the non-rebreathing mask is also what is called as the NRBM. So many questions have been asked regarding this in all types of exams. It can give 90%. It works between 12 to 15 liters, right? So it gives 90% out of all the low flow devices. This non-rebreathing mask gives the maximum FiO2 or oxygen to the patient. This was asked in the exam, right? Then high flow devices, you've got something called as the high flow nasal cannula. This can give almost 100% oxygen. In fact, this is maximum out of all of them, but it's a high flow device, not a low flow device. Okay, this works at 60 liters, giving 100%. This is what is called high flow nasal cannula. It looks something like a ventilator. Yes, there is a nasal cannula, but the machine from which it goes, it looks like a ventilator, right? So it's different from a normal nasal cannula. A normal nasal cannula is what is seen like this. This is a normal nasal cannula, right? And high flow nasal cannula is here. This is what is called as high flow nasal cannula. Okay, high flow nasal cannula. This can give almost 100% oxygen to the patient. It works at 60 liters, right? But point is that this machine more looks like sort of a ventilator from where it's getting delivered. Okay, so high flow nasal cannula becomes a high flow device, and the Venturi mask also becomes a high flow device. Venturi mask, also becomes a high flow device. But the only catch is that the maximum FiO2 given by Venturi mask is only 60%. It's not even 90%. So if you will compare Venturi mask with non-rebreathing mask, you will find that non-rebreathing mask gives more oxygen than a Venturi mask. Then why is the Venturi mask important? Because of the reason that it is a fixed output device. Fixed output means you know what you're giving to the patient. So if you have attached the red colored one, you know you're giving 40%. If you attach the green colored one, you know you're giving 60%. This is what is called as fixed output, right? If you put the nasal prongs, you have no idea whether how much oxygen is going. I am saying maximum is 44%, but how much is going, I don't know. Maximum is 60%. How much is going, I don't know. Same thing with non-rebreathing mask. I know the maximum given with is a non-rebreathing mask, and this gives 70 to 90%. I totally agree. But how much is going? I don't know. I'm speculating it will be 90%, but I don't know whether it is 90% or not. But when you speak of a Venturi mask, you absolutely know how much is going to the patient. If I put a green colored one, I know it is 60%, red colored one is 44%. Hence, it is called fixed output device. And this was the question which was asked this time exam, the previous exam, January. So which is the one which provides you the fixed controlled oxygen or the exact oxygen? It is delivered by the Venturi mask. Okay. All these, yes, they do deliver, but you cannot be sure how much is going to get delivered, right? High flow nasal cannula, yes, I know it is going to give 100% maximum out of all of them, but you can't be sure. In a Venturi mask, ideally you are sure it is what is called as a fixed output device, exact oxygen. That's the word for Venturi mask. It is called as a fixed output device. Thumbs up everyone, clear? Oxygen delivery systems are very important, so you need to be studying this before you go for the exam. Okay. Any doubts, please ask me. Otherwise, next question. Okay, so these are the various masks, guys. Hopefully everything is clear to you. This is a nasal cannula, nasal prongs, simple face mask, right? Standard face mask or Hudson mask, non-rebreathing mask, high flow nasal cannula, and the Venturi mask, right? Venturi mask is small, Venturi that gets attached to the mask. Okay, clear? Next question. Dr. Harsh says clear. Thank you, Dr. Harsh. Okay. A patient is in the ICU and has undergone neurosurgery. The patient is now to be kept on positive pressure ventilation. A tracheostomy is to be done. Which of the following you will use? Metallic tracheostomy tube, a cuffed tracheostomy tube, uncuffed tracheostomy tube, uncuffed endotracheal tube. Okay, so right, Dr. Harsh has given the answer, and other people. Simple question was there. This was simple question, but it was just testing you, I think, your knowledge. This question which was asked in the exam, right? So here, the patient has undergone a neurosurgery, right? Patient is to be kept on positive pressure ventilation. Tracheostomy is to be done. So therefore, if tracheostomy is to be done, an endotracheal tube is out. Right? All of you have given me the correct answer. It is the cuffed tracheostomy tube, right? The reason is you want to maintain a patent airway, you want to give the oxygen, and you want to prevent aspiration. The same reason. This was the reason why we had put an endotracheal tube. The whole point of putting an endotracheal tube was the same thing, that oxygen goes inside, carbon dioxide comes out, and it prevents aspiration. In case there are any secretions or something, it gets collected here. It does not go inside. Correct. That was the whole point of intubating someone. Right. Now, during surgery, we got it done under endotracheal tube. But now after the surgery, we are planning to do a tracheostomy. They have said you have to do a tracheostomy, means endotracheal tube will be out. So if the endotracheal tube is going to be out and you're making a cut in the trachea and you're going to put a tracheostomy tube, again, you will need to have a cuffed tube only, right? Metallic ones are not used nowadays. And if you use an uncuffed tube, imagine if there is a regurgitation happening, that regurgitation will cause aspiration. If there's some bleeding happening, it can cause aspiration. It will also cause leakage of the air. So that is all the complications that can take place. You will always try to use a cuffed tracheostomy tube and not uncuffed. Okay, uncuffed can always cause aspiration, according to me, right? I'm not the ENT surgeon, but still. But when you're changing the endotracheal tube into a tracheostomy tube, I will prefer to use a cuffed tracheostomy tube. Okay, so cuffed tracheostomy tube is what will prevent the aspiration. Right, so when you're putting a tracheostomy tube, it has to be in such a way that it is cuffed, and this is what is going to prevent the aspiration also. So hopefully the correct answer is clear, and hopefully you understood the point. So it's not going to be uncuffed tube that is out. Endotracheal tube is out. Metallic ones are normally not used. Okay, nowadays, I mean, post-operatively, they can still be used. The ENT people will tell you that. But in the OT, in the ICU, normally we use a cuffed tracheostomy tube is what is used. Okay, so the correct answer is cuffed tracheostomy tube. Hopefully this point is clear. Let's go to the next one. Okay. An antidote for local anesthesia systemic toxicity. The next one. Antidote for the local anesthesia systemic toxicity. Yes, guys. What is it according to you? Dr. Khan has given an answer. Dr. Med Psycho. Others? डॉक्टर हर्ष का आंसर नहीं आया इस बार. डॉक्टर टेक विद एलेक्स का भी नहीं आया. डॉक्टर टेक विद एलेक्स. Dr. Harsh has given an option. Dr. Harsh, ठीक है. Important points, Dr. Harsh. You need to be knowing this. So, Dr. Andy, A for Andy. बाकी लोग तो डॉक्टर दवे वाज आल्सो देयर ना. नहीं, डॉक्टर प्रणव दवे. So डॉक्टर खान एंड डॉक्टर मेड साइको आर एब्सोल्युटली करेक्ट. ठीक है, एकदम करेक्ट है. 20% इंट्रालिपिड. सबसे इंपॉर्टेंट पॉइंट गाइस, ये तीनों. हाँ डॉक्टर हर्ष, इट्स ओके. Once you're attending the session, the point is after attending it should be helpful to you ना. पहले गलत करोगे तो चलता है, कोई दिक्कत नहीं है. If you make some mistake, guys, remember it's okay. Make mistakes whenever you're solving MCQs right now. Don't make mistakes in the exam. Simple. The more mistakes you make right now, you're going to get clear. Okay. The people who have their concepts clear, for them it is good. For the people who are still having some doubts, it's important to give tests now. Why do you think all the teachers, all the educators just tell you one thing? Keep on solving MCQs, keep on giving grand test Q, so that you know where your mistakes are being done, and whatever mistakes are being done, you can just rectify them, right? So don't worry, guys. Make mistakes here. We want you to make mistakes in case over here, not in the exam, because here we can discuss and explain. Okay? So most of you have given me correct answer. Dr. Andy also, and Dr. Khan, and everyone has given me the correct answer here. ठीक है, सबका आंसर करेक्ट है. डॉक्टर मेड साइको का भी करेक्ट है. बट जस्ट क्लियर द पॉइंट्स नाउ. लोकल एनेस्थीसिया सिस्टमिक टॉक्सिसिटी. ओके, एक और क्वेश्चन आया है, कर लूं क्या? तो ये आता है, ये आता है, वैसे क्वेश्चन आता है, तो मुझे क्वेश्चन आया है. ओके, एंड व्हाट इज द क्वेश्चन? लोकल एनेस्थीसिया सिस्टमिक टॉक्सिसिटी affects which organ system first? ये क्वेश्चन यहीं पे बना रहे हैं, ये पूछा हुआ एग्जाम में. CVS, CNS, RS, musculoskeletal. Okay, let's make it ABCD. Sorry. Please mark your answers. Let me know your answers. A, B, C, and D. Musculoskeletal. The question have changed slightly. Local anesthesia systemic toxicity affects which organ system first? Is it the CVS, is it the CNS, RS, or the musculoskeletal? ABCD. Next question. Here itself. ऐसी मजा आता है ना. That's why I like MCQ sessions. I like to make the questions then and there itself and then ask. All of them have been asked sometime. Even this has been asked in the exam sometime. Dr. Khan was the fastest finger first. Tuck! I asked the question and Dr. Khan gave the answer. Correct. Dr. Khan, absolutely correct. CNS. So when you say if there is a local anesthesia toxicity, guys, okay, remember CNS gets affected before the CVS because it is easy for the drug to cross the blood-brain barrier since it's working on the nerves, right? CVS toxicity occurs later, CNS toxicity affects first, and that is the reason. If you remember, let me go back. Okay, let me go back slightly. If you remember when I was discussing with you local anesthesia here, remember I told you bupivacaine is the most cardiotoxic local anesthesia agent. This was the reason, because bupivacaine is one drug where your cardiac complications occur at the same time as your CNS complications. The patient lands up immediately in arrhythmia along with convulsions. and that is why it is said to be the most cardiotoxic, bupivacaine, right? And as Dr. Khan has put up, right? So as he has said correctly here in this question over here, okay, that the first thing to be affected is CNS routinely, but it is only with bupivacaine toxicity that you get the CVS at the same time as CNS, okay, and hence bupivacaine is called as the most cardiotoxic. This is an important question which has been asked in exam. Most cardiotoxic, ठीक है, right? Dr. Med Psycho, blood-brain barrier reaches easily, correct, ठीक है. Now other points. Now we've discussed local anesthesia systemic toxicity. Okay, so when we speak of 20% intralipid, guys, this is what is called intralipid. Intralipid normally is the same thing which is used for total parenteral nutrition in the ICU. So they say that intralipid is what forms complexes with bupivacaine in the blood and takes it out. Okay, so intralipid, it works like a binding agent. You know, it kind of binds to the bupivacaine, and then it takes bupivacaine out of the system. And that is why this 20% intralipid has become so important in the treatment of local anesthesia systemic toxicity, right? It is what has been used. So this was about total local anesthesia systemic toxicity. So remember, 20% intralipid is for local anesthesia systemic toxicity. Dantrolene sodium is for what then? Let's clear other doubts. Dr. Harsh was asking about this point. Yes, anyone? Dantrolene is for what? Let me change and make the options here itself. Okay, so dantrolene sodium is used for what? Dantrolene sodium is used for local anesthesia, to the option. Let's keep it as malignant hypertension, malignant hyperthermia, neurolept malignant syndrome, none of the above. That's how questions come in the exam. Okay. Life in a great moment, correct, absolutely correct. Dantrolene sodium can be used for malignant hyperthermia, which brings me to one more question. May I? Since we are discussing, correct. Here the correct answer was malignant hyperthermia. So next question based on this itself. Malignant hyperthermia is a disorder of which channel? Sodium, potassium, calcium, chloride. Next question. Nice, nice all of you. Malignant hyperthermia was the correct answer. Uske upar next question on that. Malignant hyperthermia is a disorder of which channel? Sodium, potassium, calcium, chloride. Can you see? That's how the questions come in exam. Exactly ऐसे question आते हैं. डॉक्टर लाइफ इन अ ग्रेट मोमेंट सेज RYR चैनल ब्लॉकर, करेक्ट. लेकिन इसमें से कौन सा क्या चैनल है? डॉक्टर हाफ इंजीनियर सेज सोडियम, डॉक्टर मेड साइको सेज ड्यू टू एक्सेसिव मस्कुलर हार्ट, डॉक्टर मेड साइको सेज सोडियम, डॉक्टर हर्ष सेज कैल्शियम, डॉक्टर खान says calcium, and doctor someone else has also said, Dr. Khan has said calcium before also. Calcium, guys, it's not sodium. नहीं, sodium आंसर नहीं है. तो चलो, then we'll discuss malignant hyperthermia also. Important point, calcium. So dantrolene sodium, guys, remember what is it basically? Dantrolene sodium blocks the release of calcium. That is why it is used in malignant hyperthermia. What is malignant hyperthermia? So I'm just discussing that in short. Malignant hyperthermia, guys, is a genetic disorder of sarcoplasmic reticulum. ठीक है? It's a genetic disorder. मतलब ये जीन में होता है. It's inside the gene of the person. It's not there in everyone. Someone who has the gene is going to be predisposed to malignant hyperthermia. So this person with a genetic disorder of sarcoplasmic reticulum and ryanodine receptor gene abnormality. What is ryanodine receptor? It's a calcium release channel in the muscles, right? So all this is in the muscle, sarcoplasmic reticulum and all this. So when this patient has genetic disorder and I expose this patient to anesthesia drugs, halothane, most common, succinylcholine, or even lignocaine. So when I use these drugs, these anesthesia drugs, volatile anesthetic agents, succinylcholine, lignocaine, suddenly something goes wrong with the calcium release channel, the ryanodine receptor, and भर के calcium release होता है body में. All the muscles in the body start releasing calcium. All the muscles, from all the sarcoplasmic reticulum, calcium is getting released suddenly. Top to bottom, imagine how many muscles are there, and so much calcium is getting released. So this changes the electrolyte imbalance of the body. More calcium is going to get metabolized. So you might, because electrolyte imbalance chala gaya, arrhythmias ho gaya. Because so much calcium is getting released, more metabolism, it increases the temperature, it increases the carbon dioxide production, right? Increases CO2. Because muscles are getting involved, it can also cause myoglobinuria. All of this can cause death of the patient. What is the treatment? There's only one treatment to this condition. You please need to stop this calcium release. There's no treatment. Only treatment is to stop the calcium release. How to stop it? There's only one drug that does that, and which is dantrolene sodium. So dantrolene sodium, right? It is the drug which stops the calcium release, and hence it is supposed to be not an antidote, but yes, one of the treatments for, that is the only treatment for malignant hypothermia. Clear? हाँ, डॉक्टर लाइफ इन ग्रेट मोमेंट होगा, फीवर भी आएगा. Dr. MedPsycho says muscles relaxed. No, muscles get rigid. This causes lots of muscle rigidity. In fact, muscles become more rigid. There's masseter muscle spasm that you say. So muscles become rigid. It causes muscle rigidity. Dr. MedPsycho. बस इतना ठीक है यार. Exam से पहले don't need to go too much in detail. All these points are sufficient to know for malignant hypothermia. Last point. If a patient of malignant hypothermia comes for anesthesia, if you have to give GA, drug of choice is propofol. If you have to give local anesthesia, drug of choice is procaine. Okay. Remember, dantrolene is treatment. Dantrolene is not for giving anesthesia. Dantrolene is not anesthetic drug. It is for treatment of calcium release, to stop the calcium release. If this patient is coming for, Dr. Life in a Great Moment says BP increase or decrease. Increase होएगा ना, पहले increase or फिर decrease. Dr. Life in a Great Moment. Arrhythmias, increase in temperature, carbon dioxide, myoglobin. All these will take place. So what will happen? First, there is increase in blood pressure, changes in blood. I'll rather put it as changes in blood pressure, and then it will cause decrease. Right? Initially there will be changes, na? Pehle increase hota hai, because whenever there is hyperthermia, there is always first increase. In fact, increase in carbon dioxide will also increase the blood pressure. So thoda sa BP increase hota hai, and then everything goes down and causes death of the patient. Okay. Thankfully, this gene is not there in most of the Indians. Okay, mostly. So mostly I will say none of the people who have worked in anesthesia in India have encountered it. Some people say South mein fir bhi hai. I have not but come across to anyone that who has given me report of this. It's only once in my life that I have seen one patient in my hospital who was RYR gene positive. Okay, so and how was that detected? Because that girl, she had some muscle weakness. So basically muscle paralysis nahi hota hai. There was muscle weakness. So the parents investigated her, and then they got a genetic profile done, and then it was turned out that she was RYR gene positive, probably malignant hypothermia. That's only one patient I've seen. That too, she was not given anesthesia. Okay, she was not. The surgery was not done. Otherwise, we've not come across. So hopefully this point is clear. Okay, more points are there. So this was about dantrolene sodium. It is for malignant hyperthermia. Flumazenil. Okay, so I'm not going to discuss more questions. I'm giving you the answers straight away. Flumazenil is basically a benzodiazepine antagonist. So if you have given drugs like midazolam, if you have given drugs like lorazepam, okay, if you have given drugs like alprazolam, right, diazepam in high doses, where these drugs have caused their side effects, that is where this can work as a benzodiazepine antagonist. And naloxone is basically for opioid antagonist. Okay, so therefore all of them are antidotes. Dantrolene sodium is for malignant hyperthermia, flumazenil is for benzodiazepine, naloxone is for opioid, and intralipid is for local anesthesia systemic toxicity as a treatment. Benzodiazepine antidote is flumazenil, na? Dr. MedPsycho. Benzodiazepine antagonist. So flumazenil is basically benzodiazepine antagonist, and naloxone is opioid antagonist. Okay, clear? Dantrolene used for malignant hyperthermia treatment, and 20% interlipid is for local anesthesia systemic toxicity treatment. Dr. Ayanika Chauhan says why anesthesia was not given. देखो ना, rather than अभी the class everyone is interested उसको anesthesia क्यों नहीं मिला? Because from that patient we took a death on table consent, high risk consent. The case was not, it was not an emergency surgery, Dr. Ayanika. It was not an emergency surgery. It was a planned surgery, and this patient had RYR gene positive. So we needed to have dantrolene sodium. When we inquired in Delhi, I think the last time dantrolene sodium was available in Delhi was 5 years back or 8 years back. After that, dantrolene has not come, and that is why they have said that unless and until you have dantrolene sodium with you, you cannot start a case of Raynaud in patient. In case something goes wrong, then who will be responsible? It was not a planned surgery. It was not an it was not an emergency surgery. Okay, it was something where they were just looking out. Arey, something like plastic surgery, yaar. A young girl coming for plastic surgery, that is not an emergency surgery. Plastic surgery is never emergency most of the times, huh? All of you. Facelift is not emergency. I'm not talking of people who have come with post-burn contracture neck. You must have seen people with burns, post-burn contracture neck. That is important. But you know, people coming for facelift is not emergency surgery. You know, recently there are 2 reports of 2 actors abroad who were trying to get themselves operated, who passed off and expired during a procedure. So plastic surgery is never an emergency surgery. It's planned. Okay, everyone, may I go forward? Next question. सबको एनेस्थीसिया में इंटरेस्ट है, मतलब सीरियसली मस्त, नाइस, आई लाइक इट. People are keen on anesthesia. Which one is incorrect regarding ACLS? Okay, so A, B, C, D are the 4 options. So which one is incorrect regarding the ACLS part of it? This was asked in the exam. Simple. Dr. Khan gives the answer. Correct. B. Dr. MedPsycho B. Correct. Dr. Vishnu says B. Correct. Absolutely correct, all of you. Correct. Dr. Andy says B. Correct. सब लोग correct हो. Simple question था. A for airway, B for breathing, C for circulation. But D for what? Okay, all of you are right. D is not dehydration. Now my question, if D is not dehydration, then D for what? Remember, this is ACLS. I am not talking of BLS. Aajkal, when you speak of BLS, remember it has become CAB, chest compression, airway and breathing. Alright. So my question is D. Now I'm talking of ACLS. ACLS comes after BLS. Okay. So ACLS may, it becomes ABCD. So if ABCD, if A is airway, B is breathing, C is circulation, then D is for what? Dr. Pranav says disability. Very nice. D is for disability nowadays. In fact, they've also added E, which is for exposure. Correct. A, B, C, D, E. Right. In fact, many times in old times, the D used to also to be for differential diagnosis. So, if they give you disability, even that is correct. Differential, agar by chance someone is given, even that would be correct. So let me discuss both the things out with you. So dehydration is not the point, all of you know. Nowadays, the primary ACLS survey says airway, breathing, circulation, and disability is basically your neurological assessment of the patient, right? It's all about the neurological assessment. E is for exposure, just to see any other injuries, marks, or whatever else is there. So it becomes A, B, C, D, E survey. In the past, also, as I said, again ACLS used to be like this. A for airway, where you put endotracheal tube and all. B, you're giving the breath. C, you're maintaining the circulation. And D, you are trying to think of the differential diagnosis. Means you're trying to think of the 5H and 5T, right? That was about it. So let's go to the next question. Okay. Again, this question has been asked in exam. So please tell me the answer. And all of the people have different answers for this, right? Medicine people also have discussed these questions out. So everyone has a different answer or a viewpoint to this. Right, Dr. MedPsycho, correct. I've got more questions on ACLS and BLS also that we'll do today a little bit, and whatever is left we'll do tomorrow. So questions are there, don't worry. As I said, I'm concentrating only on those topics, which is like oxygen. I took endotracheal tube. We'll take care of CPR and ACLS because that is where maximum questions are coming nowadays. So this answer. As I said, I am going to give a different answer from all of you that you know. Okay. And I may be wrong. I may be wrong, but I want to discuss it out. Okay. As I say, let me give that disclaimer beforehand. Someone will say, sir, you discussed with me wrong. So let me put a disclaimer. And what is my disclaimer? My disclaimer is that this is according to me, from what I know. Okay. And let me put it in writing. I may be wrong. But if I have to think about the answer, and the question comes in exam, because no one tells you these are the words given in the exam or not. But if someone will ask me, what will be my answer to this question which has been asked in the exam? Most of you have given the answer C, and I don't agree with C. As I said, a lot of people have given this answer. It has been discussed everywhere. So most of the people have marked it C. I will not go for C. I will not. I will go for D. Okay. Why will I go for D? That I'll explain to you. Dr. MedPsycho says like subject to correction. Absolutely. So disclaimer, let me put it like this. Dr. MedPsycho is actually making fun of me, but ठीक है चलो. Correct. Let it make it light ना. एकदम पढ़ाई इतना दिमाग पे ऐसे थोड़ी heavy नहीं होना चाहिए ना. Let's put a disclaimer. That's my disclaimer that my answer is leukotriene antagonist. First, let me go for why I think. I'm not talking in terms of medicine. I have also done chest medicine, right? I'm a qualified chest physician also. I am sitting in my OPD, right? So a patient comes to the hospital with an acute attack of asthma. Patient has got acute asthmatic attack, absolutely acute. That means the patient is breathless, difficult to breathe. He's having palpitations, correct? And on examination, the saturation is 88%. Remember, normal SpO2 should always be 95%. In fact, you remember during COVID, government used to say, Amitabh Bachchan used to say, it's less than 93%, run to the hospital. All of you remember during the COVID times, we used to say your saturation goes down to 93%. Here the patient is 88%. In 88%, how can you say oxygen is not needed by the patient? Whatever way you should give oxygen to the patient, it is urgent. According to me, oxygen should be given to the patient because this patient is desaturated. Patient does not have oxygen. If you know, there is something called as the S-shaped hemoglobin curve, right? The more and more this this falls down, it is going to go like this. Within 3 to 4 minutes, 10 minutes, as soon as the SpO2 is decreasing, the PaO2 is going down of the patient. Thumbs up, everyone. Yes. Yes or no? Right. So normal SpO2, as I'm discussing with you, is 95% or more. In COVID, they used to say if it is less than 93%, they used to say rush to the hospital. Here in this question, our patient has SpO2 of 88%. How can you say that oxygen should not be given with mask and with reservoir? Why? Because with reservoir, you can give almost 90% oxygen to the patient. Don't you think it's going to be beneficial? Dr. Kishore Ramurthy says, sir, can we get the PDF in Telegram? Of course, of course. That's why I'm telling you, people need to remind me to save. Dr. Kishore, you need to tell me to save, because many times I forget it. Before I see, today I'm taking one class, tomorrow also another class. I'll be discussing more questions tomorrow also. So I'll be saving it today and tomorrow we'll be giving the PDF. Well, I tried it today also, but let me see. It's better to give tomorrow when I have all the questions. Okay? You'll get the PDF. Just let me know when to. I have to save it when I'm finishing my class today. Okay. So as I was saying, this is my way of saying. A lot of people have normally will disagree with what I say, but I am telling you, just go logically to think about it. That if this patient is with saturation 88%, will you tell the patient that take IV hydrocortisone, take magnesium sulfate and leukotriene antagonist? To which I did a search study. And you see, this is the study which I found out. Okay. And this is the study, right? According to me, as I said, you will see neither montelukast nor zafirlukast has a role as a rescue medication during acute asthmatic attack. This is a study. These are leukotriene receptor antagonists. and they are used to prevent and treat chronic asthma. Guys, remember, if you are giving Montelukast to someone, from what I remember, I practice anesthesia now, but Montelukast basically was not given for something which is immediate. It was basically to prevent, guys. That was the point, na? These are leukotriene antagonists, right? And they say that Montelukast and Zafirlukast per se have no role of a rescue medication during acute asthmatic attack. This is what I found out. So according to me, this is what I am discussing. Plus, this is what is my knowledge, and I may still be wrong. But according to me, you cannot deny oxygen by mask with or reservoir or anything to a patient, whatever be it. A patient comes in asthma, he should be given oxygen, whatever said and done. There's a difference if a patient is with COPD. If a patient comes with COPD, that's a different thing. In that case, forget main oxygen by mask with reservoir. Here I will try BiPAP. Here I will try CPAP. Okay, again that point is something different. But when a patient is complaining of asthma, he needs to be given oxygen immediately. Hydrocortisone, anti-inflammatory, you will give. Magnesium sulfate, yes, you will give. Oxygen, you will give. Leukotriene antagonist actually in emergency has no role according to what I know. So here, which one of the following is not used in immediate management of this patient? It is leukotriene antagonist. Hydrocortisone, magnesium sulfate, which is used nowadays. I'm not denying it is used as one of the medicines which is given to the patient, and oxygen should be given. Leukotriene antagonist, according to me, it has no role as a rescue medication in acute asthmatic attack. I know people will disagree with me. A lot of people will put on the comment, sir, you are this, sir, you are that. That's okay, yaar. It's okay. That is my point of view. Na? I'm entitled to my point of view. And that's exactly why medical profession is called practice. It's not always that two people will agree to the same thing. And I don't agree to the fact that oxygen should not be given. I'm a chest physician myself. I know a patient comes in emergency, you have to give oxygen to the patient, irrespective of what it is. First save the life. We'll take care of things later on. Okay, that's according to me. Okay, according to me. All right. So I will go with leukotriene antagonist as one of the drugs not to be used. Next question. Okay, simple. Okay. NEET preparation with aspirant. Array, this is NEET PG, Dr. NEET UG. This is NEET PG. Don't worry. Once you get into NEET PG, once you get into MBBS, this is exactly what you'll be doing day in and day out. Asthma, यही सब काम करोगे. हाँ, so guys, give me the answer. You are giving inhalational anesthesia agent, which is the one that needs a specialized vaporizer. So Dr. Vishnu, Dr. Khan have given an answer immediately. Fastest finger first. As I say, Dr. Med Psycho, correct. And all of you are correct. Simple question. It is desflurane. But why? That's the point. So if you will see anesthesia machine, na, ये है anesthesia machine. So anesthesia machine में here you find the cylinders. This is oxygen. Here is nitrous oxide. These are cylinders. Remember, after that there is something here which is called the vaporizer, which you can see, right? Here is the vaporizer. So this is one vaporizer that you see. If you have to see a schematic diagram, can you see here is the vaporizer, right? This is a vaporizer. Vaporizer is what contains the inhalational agents, right? Now if you look at the vaporizers, look at them. So this looks one way, this looks, in fact, apart from color, the first three in design look similar. Sorry, similar design, but can you say this design is only different? This one has something over here to put, plus this is slightly huge, right? And I don't know, it's not visible, but there are small electrical supply over here. It has got small, as a round points over here, which tells you about the electrical supply. It is not there in this and this. It's not there. So the first one, this you see, the one that you see over here, this is for sevoflurane. The next one that you see is isoflurane. This one is halothane, and the last one that you see is desflurane. If you will see the colors, sevoflurane, guys, is yellow in color. Again, that's important. Isoflurane is purple in color. Halothane is red in color. Desflurane is light blue in color, right? When you speak of desflurane, you find it's got a different vaporizer compared to others. Most unique, right? Dr. Med Psycho, that word is correct. I love that word of Dr. Med Psycho. He says it is the most unique. Let me put it like this. It's the most unique. Why it's the most unique? Let me put that word absolutely correct. right? And the reason is because this desflurane, it boils at 23 degree or room temperature. Boils at 23 or 24 degrees centigrade room temperature, and it has got the highest saturated vapor pressure. You don't need to remember all those things, but the point is, compared to other inhalationals, it boils at 23 degree, which is room temperature, right? And it's got the highest saturated vapor pressure, means immediately it becomes a vapor, it becomes a vapor, it becomes a vapor. So it does not go properly to a patient if you will use a normal vaporizer. Because of this reason, you need to have a special vaporizer which is electrically heated. This vaporizer is electrically heated, and this is called as TEC6, TEC6. That name is not important. I don't think it will be asked to in the exam, but since we are writing, might as well just write it down, right? So this is the only one that requires a special vaporizer for delivery, which is desflurane, because it boils at 23 degree or room temperature. It has got the highest saturated vapor pressure, and for which it needs to be electrically heated before the delivery, right? And hence it's got a unique vaporizer. Remember, these colors are important. They are also asked in exam. You are supposed to be knowing them. Okay, colors. Now, before laparoscopic surgery, what advice is given to the patient? Next question. So before laparoscopic surgery, what advice should be given to the patient? Okay, so Dr. Med Psycho, Dr. Vishnu, Dr. Andy, correct. All of you gave me the correct answer here. 8 hours. Okay, 8 hours. Now remember, laparoscopic or any surgery, it's not about laparoscopy. It's about laparoscopy is this, but I'm talking of any surgery. For any surgery, the NPO guidelines say NPO guidelines. NPO means nil per oral, or it's also called as nil by mouth. Means before a surgery, patient should be fasting. Why should a patient be fasting? You only think if you're doing a surgery and if the stomach is full of khana, all that stomach contents will come into the esophagus, and from here it's going to go inside the lungs. That is the reason why you need to intubate a patient, so that it has a cuff, and when a surgery is being done, in case there is regurgitation taking place, the aspiration gets prevented. That is why you need to intubate a patient, correct? So therefore the point is, the stomach should be empty before a surgery is being done, right? That's why you need to put endotracheal tube, correct? Aspiration has to be prevented. You want the stomach to be empty. So what the books say, new guidelines 2, 4, 6 and 8. So 2 hours is said to be for clear liquids. Clear liquid में दारू नहीं आता है. It has been a question asked to me practically. Practically, clear liquids does not include alcohol. It is also clear, by the way. Someone has asked me, not someone, many people have asked me, sir, tomorrow is my surgery. Can I have a little bit? No, you can't have. You can't. It is clear, I know. But books don't say you should have it to come before the surgery. No. 4 hours is for breast milk. Right? 6 hours is for light meal or any other type of milk, like non-formula milk, okay, non-human milk, whatever. Okay. And 8 hours is for a heavy meal. Heavy meal means chicken, mutton, paneer. Routinely, if both are given in the options 6 and 8, what should you stick to? Again, there's a difference. A lot of people will say, sir, why not put 8 hours? But there's a second thing which has come. Initially, if you remember, when long time back, people used to say tomorrow morning is a surgery at 9 o'clock. So be NPO from 12 midnight, means 9 hours of fasting. So nowadays they say that is not right. Don't be fasting for so long. It's not needed for you be fasting for so long. It can create more problems. These are the new studies. They are saying it's better to have the adequate time which is needed. So if you're just taking a toast, a biscuit, some tea, biscuit, toast, That is exactly what you need to take before surgery. So 6 hours for that. No one is saying before a surgery that you take chicken, mutton, paneer because then you will not be eating it. So therefore, this 8 hours normally is not correct. According to me, if both the options are given 6 and 8, ideally you should stick with 6, because any surgeon will advise before a surgery to a patient that have a light meal before the surgery. No one says take a heavy meal. That's my point of view, right? So because 6 hours is not given, I will stick with 8 hours over here. But if 6 hours was given, I will, rather go for 6 to 8 hours. That is my option. Okay. And 24 hours, no, 2 hours is for clear liquids, right? And no need. Correct answer is NPO 8 hours according to this point. Okay. Next question. Okay. Your answers. Next question. So you were somewhere and saw a guy collapse. You started CPR after checking vitals, right? And soon advanced cardiac life support team arrives at the scene. What should be your next step of management? So Dr. Med Psycho and Dr. Tech with Alex says C. Dr. A for Andy says C. Ask them to apply the paddles while you continue CPR. Correct. In a way, before I start my answer, again, disclaimer. This is again a question with disclaimer. What is the disclaimer? Disclaimer. Correct. I'm using the same words that you people told me. All of you have given me the answer C. And as I said, at times I will not always agree. That is my point of view. So the disclaimer is I don't agree with C. Right? And I will show you why don't I agree with C. My disclaimer is that I will give the answer as A. Okay, why is A? What is the difference and why you people have said C? Dekho, we'll see the chart first and then I'll tell you why I have put the answer as A. Yes, A and C are very close by. Most of you have given me the answer C, but I will not stick with C. I will stick with A. Hand over the patient to them and leave. Okay. First point is stop the CPR and let them apply the paddles. No, this is out. इतना controversy says Dr. Med Psycho. Controversy नहीं है Dr. Med Psycho. देखो इसीलिए तो questions ऐसे आते हैं. But the point is if you have to read ना, so can you? This is our CPR chart. ठीक है? CPR chart. So my point is कि CPR chart में क्या लिखा है? Let's see what has been given in the chart ना, where they are asking you. The first thing is to scene safety. Correct? The scene needs to be safe. That is the first point. The next point is you check for response. Right? If the patient is responding, छोड़ दो. If not responding, then you go forward, right? And of course, you're calling for help. Call for help becomes important so that those people can get the automated external defibrillator and all, right? The help people will get all this. So these are the 3 steps. After these 3 steps comes your 4 steps. Fourth step, which is, check for the breath and check for the pulse simultaneously within 10 seconds. For the breath, you're looking at the visible chest rise. Pulse is carotid. If there is breath, if there is pulse, all you need to do is to keep the patient in recovery position. This was the NEET PG question this time around. Correct? NEET PG recall ka question hai ye. NEET PG recall question. You can check my videos also, it's there. So breath and pulse both are present. You keep the patient in recovery position. Now, if breath is absent and pulse is present, in that case, what to do? Breath is absent, na? So you keep on giving breath to the patient. Agar breath absent hai, pulse present hai, you keep on giving breath to the patient. And this is where you can try to use naloxone if you find opioid overdose, if you find the signs of opioid overdose, and keep on checking the pulse, because right now pulse was there. You never know when pulse can be absent. Last point, and the most important, when there is no breath, when there is no pulse. Okay, so if I have to summarize it, CPR, I told you CPR is an important topic. We have to see it properly and let's summarize. So there is scene safety. You check for response, you call for help, right? Then you check for the breath and pulse. Now there are 3 points to breath and pulse, right? 3 points to breath and pulse are, if there is breath and pulse, both are present, you keep the patient in the recovery position. If the breath is absent and pulse is present, in this case, breath is missing, So you need to give breaths to the patient, correct? And you will be doing, assess the pulse. If needed, you can give naloxone. And if breath is also absent and pulse is also absent, in this case, you're supposed to start the CPR. And the CPR is chest compression, airway, breathing. This is the three things. All these three things are important that you should be knowing, correct? So when breath and pulse are absent, you start the CPR, correct? We have started the CPR, and our CPR is chest compression, airway, and breathing. I'm supposed to be doing 5 cycles of 30:2, 30 chest compression, 2 breath. I'm supposed to do that. Then I need to check the pulse and rotate the compressor. It will be going on like this continuously. Chest compression, open the airway, give a breath. Chest compression and airways open, give a breath. You will be doing these cycles of 30:2. I will be doing that, right? And in case you get a defibrillator, then what will you do? You will attach the defibrillator and then you will check for the rhythm, right? And depending on the rhythm, if the rhythm is shockable, you need to give a shock. If the rhythm is non-shockable, you continue your CPR, right? But if you look at the same guidelines, guys, right, what they have said, you give the shock if you have got it, resume the CPR, right? Second point is continue until ALS providers take over or the victim starts to move. So they have said straight away, if you get the AED, you do it yourself. If not, they are saying what? Continue till the advanced life care supporters are going to take over or the victim starts to move. The same thing is there if it is non-shockable rhythm. Continue until the ALS. Of course, you're supposed to do CPR. No one is telling you to stop CPR. But you will continue the CPR till the ACLS providers take over. And once they take over, you can leave. And that is why my answer would be hand over the patient and leave. Is this clear, everyone? According to me. According to me. I'm not saying it is wrong that if I'm the doctor on duty, see, there's a difference. Now, if there is someone who's a plain, who's someone, see, I'm right now, I've done anesthesia, right? I'm working in the casualty, I've done CPR. So when the ACLS people have come, I will continue my CPR because I'm kind of trained in that. But someone who is not trained to convince to someone who is trained, this BLS is not made for people who are trained, guys. BLS is made for any roadside. This basic life support that we are dealing is for any roadside incident. It's not that everyone is MBBS doctor, everyone is anesthesia person, is a medicine person, they can do CPR. Not necessary, na? Or they know all the steps. The point is, if you are a bystander, right? That's why exactly they are not saying you are well trained in CPR or not. You are a bystander, anyone. You are a bystander. You are somewhere, you saw someone collapse. What is your first step? You will start CPR, correct? You did BLS, you checked the vitals, and you started. And after that, your ACLS team has come. The ACLS team is more qualified right now. So what you're supposed to do is that you should ideally hand over the patient to them. You should continue to that point, hand over the patient, and then you can leave. That is according to me. But if you will ask me, if I was the person giving BLS and if the ACLS people have come, I'll tell them I'm only ACLS qualified. So I will tell them what to do. But I'm not discussing whether I'm standing there or not. It is about anyone who is a bystander. What is the bystander supposed to do? Bystander means somewhere who's standing. That person who was a bystander should continue BLS. Who does not know ACLS so much should continue the BLS till the time ACLS people arrive. Dr. Med Psycho says it's tricky. That's exactly Dr. Med Psycho. देखो, that is what they are testing according to you. I am giving you the things also ना. अगर तुम ये देखोगे तो ये तो लिखा है ना इसमें. This is the chart given by ACLS, American Heart Association ना. Continue until the ACLS people arrive, right? And once they arrive, you will take over. So according to me, the correct answer, it is tricky. I'm not denying. It is a tricky question where both the options according to me are correct. According to me, it's not that the C option is wrong. Huh? You can also do that. I'll continue CPR. I'll tell them to apply the paddles and then I'll hand over and give. I can do that also. You are right. It's not wrong. It's not wrong. Correct. But the point is, according to me, then, as I said, hence I put the disclaimer, big disclaimer. Don't put me in the comments and tell me, sorry, it is wrong. It may be wrong. I may be wrong. And that is the disclaimer. That is my way of thinking for it. And as I said, no two people always agree to two things. Na? Sorry. I may be wrong. Disclaimer is I may be wrong. But these are the two options which are very close. According to me, both can be correct. But if you will go from what has been mentioned, according to me, you should be doing, if you are a bystander who does not know ACLS, who's not trained in ACLS, because the people who are coming with ACLS are ACLS certified people. And if someone is a bystander who's just doing a BLS, should hand over to the ACLS team and then go. Thumbs up, everyone. Is it clear? Okay. Are you okay? Hopefully. This is the recovery position, guys. Okay. So chest compression, airway and breathing. So as I was discussing with you, chest compression is always 100 to 120 per minute. Okay. Anyways, we'll discuss this later on. There are more questions for that. We'll do that later on. Okay. Dr. Tech with Alex says clear. Clear. Correct. Dr. Tech with Alex. See, as I said, that is my way of thinking. Now, that is my point of thinking regarding any questions and doubts, guys. Please ask me. So this is my way of thinking. Okay. As I said, I'm not saying I may be correct always. I've written out. I may be wrong. Other people also may be right. But I am saying from my knowledge. Now, this is what I am applying my knowledge. And that is why whenever some questions have been asked in the exam, neither is everything a perfect recall, nor it's a perfect question, nor there are the perfect options. You try to think from whatever you have got. Right. The point is to have a discussion. So we know the discussion, how you have to approach it. And a question like this comes, you have to use your mind. That's how you're supposed to solve the exam, guys. Okay. And that is why everyone tells you have your concepts clear and then approach the question. Right? Have your concepts clear and then approach the question. All of you will be correct. Don't worry. Next question. Which of the following grading system is being depicted in the image? Malam Patti scoring, ASA scoring, AHA scoring, AHA grading, and Cormac-Lehane. Dr. Vishnu is given an answer. Dr. Khan, Dr. Med Psycho, Baki log, Dr. A for Andy, correct. All of you are correct, absolutely correct. Malam Patti scoring, absolutely correct. Okay, so this is what you see: Malam Patti 1, Malam Patti 2, Malam Patti 3, and Malam Patti 4. Right. What is the difference between all of them? The point is, Malam Patti mein always you will be seeing here the uvula is seen, right? Then you're looking here, which are the tonsillar pillars. Then there are small areas which you can see over here, which are the fauces. Then you see the soft palate and the hard palate, right? In Malam Patti 2, what happens? The tip of the uvula is not seen. So tip of the uvula is not visible, and pillars and fauces are half, soft palate and hard palate are visible. When you speak of Malam Patti 3, Malam Patti grade 3, here you will find the base of the uvula is not seen, right? Otherwise, in fact, pillars are now gone away, right? You will see those pillars are not seen over here. The fauces are not seen, but soft palate and hard palate are seen. In the last, you just see the hard palate. So, if you see only the hard palate, it is Malam Patti 4. If with the hard palate, you also see the soft palate, correct, and you only see the base of the uvula, it becomes Malam Patti 3. Now, if only the tip of the uvula is not visible and everything else is visible now, it becomes Malam Patti 2. If everything is visible, everything, it becomes Malam Patti 1. Remember, Malam Patti 1 and 2 are relatively said to be easy intubations. Malam Patti 3 and 4 are said to be correct. Dr. Med Psycho says base of the tongue compared to oropharyngeal opening. Correct. And Malam Patti 3 and 4 is difficult intubation, right? So the whole point of doing Malam Patti was what? They say the patients in whom you can see in Malam Patti, you can see, it's clear, the uvula, like Malam Patti 1 and 2. In those patients, you can see the vocal cords clearly. And that is why Malam Patti 1 and 2 normally are said to be easy intubations, because in those patients you can intubate. Malam Patti 3 and 4 normally become difficult intubations, because in those patients the vocal cord will not be visible. And intubation is so important for us in anesthesia. I just discussed why, right? So therefore, before the surgery, we always do that Malam Patti examination, so that when you do Malam Patti before the surgery, you know whether intubation is easy or the intubation is going to be difficult. If it is going to be difficult, you should be prepared for difficult intubation. If it is easy, well and good for you, no harms. right? Because in easy intubation, you will be seeing the vocal cords. You can intubate the patient. In difficult intubation, you'll not be seeing the vocal cords. So Malam Patti 3 and 4 primes you before the surgery that you know that you're dealing with a difficult intubation. So you will keep your difficult intubation cart ready. You will keep your laryngeal mask airway. You will keep your fiber optic ready. You will keep a stillet ready. I will keep a tracheostomy set ready. In case there's an emergency or something to be done, I will take care of it, right? So this is the reason why difficult airway becomes so important, and Malam Patti grading is one of the ways to understand that. Okay, next question. So that was a simple question. So these are the last 3-4 papers that I'm discussing with you. These were the last 3-4 papers, and tomorrow I'll be discussing another 2-3 papers. Right? The last questions which have been asked in the last exams. So these are all previous years, guys. All these questions slightly twisted. These are all previous years questions. All of them. It's basically a complete revision of all our PYQs. Dr. Vishnu has given the answer. बाकी लोग और लोग जल्दी. Dr. Khan has given an answer. Correct. ठीक है. So correct. All of you have given me the correct answer, and that answer is B. Absolutely correct. So if you will see, the question has been asked about IV anesthetic agent. If you see sevoflurane, desflurane, halothane, which causes hypnosis. What is hypnosis? Hypnosis means the one which is an induction agent. This is what they are asking you. Induction agent means the one which causes anesthesia, right? So you will find sevoflurane, desflurane, halothane, isoflurane. These are all inhalational agents. So they are out. This question is out. Propofol, thiopentone, etomidate. These are all IV. Correct. This can be one option. Sufentanil is IV. Sugama Dex is IV. Tramadol is IV. But sufentanil and tramadol are opioids, right? They are not causing hypnosis. And Sugama Dex, guys, is a reversal agent for neuromuscular blocker, right? And rocuronium, vecuronium, atracurium are again IV, but they are not causing hypnosis. These are same muscle relaxants or muscle paralytics. You can call them non-neuromuscular blocking agents. Same. So therefore, the correct answer is B, which all of you have pointed out correctly. Okay, so these are the IV induction agents, or these are the IV agents which are causing hypnosis. So these are called the IV induction agents. So if you have to classify, guys, remember the classification of all the drugs producing anesthesia, which I will say induction agents. So induction agents are also called as hypnotic agents. These are all the drugs producing hypnosis also. We can broadly classify them into two types. You can classify them into inhalationals, which are given by the mask. You can give by the IV drugs. I'm not talking of muscle relaxants here and opioids now. So the inhalationals, guys, can be basically of two types: the old ones, the new ones, the ones which are in cylinders. So you have drugs like nitrous oxide, inhalationals like nitrous oxide. You have Entonox, Xenon, which are kept in cylinders. You have ether. Old ones, you have trilene, chloroform, methoxyflurane, halothane, enflurane, desflurane, sevoflurane, isoflurane, right? If you speak IV, so let me just classify here only now, induction agents. IV. So IV can be classified into two types, right? One are basically fast acting and others which are slow acting. So in slow acting, guys, I'm not saying that opioids are totally not there. They can still be working, but they are normally not preferred. We prefer the fast acting ones. The fast acting ones are the ones which you will find two types: barbiturate and non-barbiturate. The barbiturate ones are thiopentone and methotrexate, which you people are supposed to know. And non-barbiturate are basically propofol, ketamine. Okay, you have etomidate. Slow acting, you will get benzodiazepine and you will get opioids. So these are all the drugs which can be used for induction agent, and out of them, what we normally prefer are to use the fast acting drugs, right? This is what is preferred. If someone has an IV cannula, when someone does not have an IV cannula, like pediatric patients, we used inhalational agents, and inhalationals mein what we prefer is to use sevoflurane and halothane if it's only for induction. And inhalational agents normally are used for maintenance of anesthesia, right? So going forward, so this is about the induction agents and hypnotic agents classification. Okay, this is the device. It works on which principle? Yes, guys. So this works on which principle? So I'll take another 2 questions and then we'll stop the session today. Then again we'll discuss tomorrow. Dr. Vishnu has given an answer. Dr. Med Psycho has given an answer. Dr. Andy, other people. So I'm just looking at the responses. Huh? Dr. Khan says D. Correct. This is called Venturi principle. Okay. This is a Venturi device, so which brings me to the next question. I'll discuss the point. Okay. This is a Venturi mask we discussed. This was also asked. Okay. So please mark your answer. The same thing. Remember last three papers, every time they've asked something related to the Venturi mask. Correct? Here also the answer is Venturi mask. Right. Okay. Remember the last three papers they have asked Venturi mask. Huh? So here the correct answer is again Venturi mask, and the previously again it's the Venturi principle. Now, what is the Venturi principle, guys? Now this question can be made slightly difficult. How can they make it difficult? If they just cut the Venturi principle and they'll write it like Bernoulli's law. If they write it Bernoulli's law, this becomes difficult, guys, because then in that case they'll just give you this instrument and they write Bohr effect, Boyle's effect, Beer-Lambert's law, and Bernoulli's law. So Bernoulli's law is basically for fluid and Venturi principle is for air, and since we are using it for air, we call it Venturi principle, but it is based on Bernoulli's law, which is for fluid. What it causes, can you see there's a small hole here pe? Small opening, there's a wall sort of a thing. So what happens is oxygen normally comes from here, and what happens is air from the surrounding goes from here because of the hole which is present, and because this air and this gets mixed together, this is what is called as air entrainment. You don't need to do anything more than that. This is called air entrainment A, based on Bernoulli's law, which is based on fluid, and this is then becomes a fixed output device where you know how much is going to the patient. So if you start 15 liters, you know 60% is going to the patient. Okay, so this is what is the Venturi mask. Now, this was the Venturi mask. Normally, when we say a simple face mask is this, right? This is the non-rebreathing mask. Nasal cannula we've already seen, and high flow nasal cannula we've already seen. So all these points are there. So I think let's take one more question, right? So we still have about 5-10 minutes. I'll take about 1 or 2 more questions and then we'll take tomorrow. Dr. Tech with Alex says, is this Bernoulli law of class 11th? Ha, correct. Correct. All those laws are there, na? See, if you will think, all the questions come in exam, na? So they always ask you Henry law. Yeah, there's something called as Henry. There is something called as Boyle's law. Okay? We just discussed there is Poiseuille's law. Okay? अरे सबका law आ जाता है यार, everything. Physics, chemistry, nothing leaves your thing forever. You think when you become a postgraduate, when I took up anesthesia, you think I had to forget studying anatomy? No. Spinal epidural intubation is full of anatomy. Blocks is full of anatomy. You take physiology, you take anesthesia, you think physiology is going away? No. When you're studying, you have to study the effect of anesthesia drugs on the physiology of the body. Okay. Whatever branch you take, nothing leaves you ever in life. Dr. Tech with Alex. Okay, ये वही Bernoulli's law है. Correct. So there are so many things which are asked in the exam. There is something called as Frank Starling's law. People remember cardiac physiology. Frank Starling's law. Correct. So all these things, some questions off and on, they ask in physiology based on that. Right. Let's not go into laws. Next question. Unresponsive patient is being transferred in an ambulance. The monitor attached shows the following rhythm. What should be done immediately? Yes, guys. Answer to this. Dr. Med Psycho says B. Other people. Dr. Khan says B. Dr. Eva, correct. Everyone has said B. I will also stick with B. Okay, I will also stick with B. Right? Correct, all of you. But there's one more point. See, if you have to build up controversy, you can always build up controversy in this question also. But how it's not a controversy, let me tell you that. See, the point is how to approach the question. They are saying an unresponsive patient is being transferred to an ambulance. Okay. Unresponsive patient is being transferred in an ambulance. मतलब patient respond नहीं कर रहा है. Remember when we were seeing CPR, the first thing was scene safety, check for response, and call for help. And after that, the next step is check breath and pulse. Understood my point, guys? So the point is, if I have to build a controversy on this question, I can also say, I'm telling how to approach the question, why is this not the answer? If I can also say, response of the patient is not there. Ideally, if there is no response, now my next step should be check for breath and check for pulse. If there is no breath and no pulse, then you start your CPR, which is chest compression, airway and breathing. But this question has given you a catch. What is the catch? The catch is that the monitor is already attached and it is showing the rhythm. No, it's not cardioversion. Wait. The monitor is attached and showing the rhythm. So basically, the rhythm that you see in front of you, forget the pulse. What is the rhythm? The rhythm is ventricular fibrillation, means the ventricle is fibrillating. In this thing, the only thing which works is defibrillating the patient. It's not cardioversion, it's no medicine. You have to give a shock here. Okay, so because the rhythm seen, had there been something, remember when do you give a shock? Okay, when we were discussing defibrillator coming and getting attached, so when you get a defibrillator, you are attaching the pads to the patient, right? And then you are assessing the rhythm. Wait. So as soon as you get the defibrillator, you attach the pads and then you need to assess the rhythm. So guys, the rhythm can be two types, right? So the rhythm can be something which can be shockable and the other rhythm which is non-shockable rhythm. The rhythm which can be shockable is ventricular, pulseless ventricular tachycardia. Remember this point, huh? Pulseless ventricular tachycardia or ventricular fibrillation, or pulseless electrical activity, or asystole is for non-shock, right? So whenever you're supposed to give a shock, whenever there is ventricular fibrillation, guys, irrespective of anything, there has to be shock, right? The treatment is shock. If it's a biphasic, you give 200 joules of shock. If it's a monophasic defibrillator, you give 360 joules of shock, right? And after that, they say do not do a pulse check and immediately start CPR. No pulse check is to be done and immediately start CPR. Same thing what we discussed before. Huh? A pulseless electrical activity, asystole, you cannot give a shock. It does not work in that, right? In this case, if you have adrenaline, you can give adrenaline. Otherwise, straight away start CPR. Right, and that's the same thing. After that, they said if the ACLS teams come, hand it over to them. But if you have a defibrillator and you have a ventricular fibrillation, you need to give a shock. So if you look at the question, you already know that the rhythm of the patient is ventricular fibrillation, and in ventricular fibrillation, you have to give a shock, which is defibrillator. So correct answer becomes chest compression and defibrillation. Cardioversion is not the answer. So cardioversion, guys, is more of a treatment of, I'll say paroxysmal supraventricular tachycardia, all right, atrial flutter, no, PSVT, sort of those things. And that too when the patient is unstable. If it is unstable patient, right, this is where you will give cardioversion, because stable patients in this narrow complex tachycardia, you can still give, I'm not going to go into details of all that, you can still give IV medicines, but unstable is where you will give the cardioversion to the patient. Unstable tachyarrhythmias which are there, this is where you will give cardioversion. But here the patient is almost gone. कार्डियोवर्जन पेशेंट का क्या होता है, बीपी कम हो रहा है, पल्स इज स्टिल फेल्ट, पल्स इज फीबल, हाइपोटेंशन, ऑल दैट इज हैपनिंग. But this patient is unresponsive, and this rhythm means the ventricle is fibrillating, and in some time it will become a flat line. Okay, it means some activity of ventricle is there. You are supposed to give a shock and try to revive the heart of the patient, and that is the whole point. As soon as you give ventricular fibrillation, you have to give shock to the patient to treat the ventricular fibrillation. Okay, so the correct answer here becomes B, which is chest compression and defibrillation. So we'll end it over here for today. All right. So thank you for joining me. Any questions and doubts, please ask me. I'm saving this PPT now, right? And this will be available on the group that we have. Okay. So this PDF, it will be available in the PDF format. As I'm saying, this will be available as PDF on the Telegram group. You people can go and check it from there. Any questions and doubts, please ask me. I'll try to help. And tomorrow again, I'll start at the same time. Mostly same, 5 o'clock, not 5:30. Probably we'll take from 5 to 6:37 and we'll try to finish off more questions. Yes, guys, any questions and doubts, please ask me. Yes, guys. Thank you, Dr. A for Andy. Thank you so much. Thank you, guys. Thank you, Dr. Khan. Thank you so much. Okay. Hopefully it is helpful. Okay. Some points cleared. Some controversies. We discussed controversies also. Medical is only controversy, yeah. It's bound to be. Okay. But hopefully points are clear to all of you. So we'll join tomorrow, and this PDF I'm saving now. And thank you everyone for joining me at this session. Okay, so PDF will be available tomorrow on the Telegram. Okay, I'll save both of them, and that will be available tomorrow. So let me first save it before I discard. I need to save, keep. So by keeping, I've saved my annotations, right? All my annotations are there. We'll be discussing it, right? So all the annotations are there. Don't worry. And I'm saving it again. So let me save. All saved, guys. Okay. So everything is got saved. Don't worry. Thank you, Dr. Med Psycho. Thank you so much, everyone. Okay. Take care. All the best, and we'll meet tomorrow. Thank you. Thank you, everyone. No doubts, no. Hopefully, no doubts. No one asked me a question here. Thank you.